Today, we'll begin a simple primary care review on Down syndrome management in children. Down syndrome is the chromosome abnormality of trisomy 21. It is the most frequent form of intellectual disability. Management requires the initial and ongoing evaluation as well as monitoring for associated abnormalities. Patients with Down syndrome use the Down syndrome specific growth chart to evaluate their growth. A goal of growth monitoring is to prevent obesity. Interventions begin from 24 months of age, and caloric intake should be less than the age specific recommendations for unaffected individuals. Calcium and vitamin D intake should be monitored closely to minimize bone loss, since adults with Down syndrome have lower bone mineral density than average. Down syndrome and cardiac disease. All newborns with Down syndrome should be evaluated for congenital heart disease. An echocardiogram is recommended. Continued clinical cardiac evaluation is needed because of the high risk of mitral valve prolapse and aortic regurgitation in adolescents and young adults. Down syndrome and hearing. Newborns should have a newborn hearing screen with brainstem auditory evoked response. Infants with Down syndrome should have a repeat hearing screening at 6 months of age. Hearing should be evaluated regularly throughout childhood every 6 months until 4 to 5 years of age, which would then turn into a yearly checkup. Any child who fails screening should be referred to an otolaryngologist for further evaluation and management. Down syndrome and ophthalmologic disorders. An ophthalmologic assessment should be performed before 6 months of age to detect strabismus, nystagmus, and cataracts. Affected children should have annual assessments of vision. Unaffected children should be examined annually before age 5 years, every 2 years after age 5, and every 3 years after age 13 to screen for disorders. The examination should be performed by a pediatric ophthalmologist or ophthalmologist with expertise in infants with disabilities. Down syndrome and thyroid disorder. Thyroid function tests of total thyroxine and thyroid stimulating hormones should be obtained in the newborn period. The American Academy of Pediatrics recommends that screening should be repeated at 6 and 12 months and then annually. Down syndrome and hematologic disorder. A complete blood count and differential should be obtained at birth to evaluate for myeloproliferative disorders and polycythemia. Down syndrome and Atlantoaxial Instability. The loss of motor skills, loss of bowel or bladder control, neck pain, neck stiffness are important clinical predictors of symptomatic atlantoaxial instability and dislocation. A lateral plane cervical spine radiograph in the neutral position with odontoid and anterior posterior views is used to examine the AAI. Down syndrome and sleep apnea. Children with Down syndrome have an increased risk of obstructive sleep apnea. Symptoms related to sleep apnea should be discussed beginning at age 1 and continued throughout childhood. Down syndrome and fertility. Fertility is impaired in individuals with Down syndrome, most likely secondary to primary gonadal deficiency. 15 to 30% of females with Down syndrome can become pregnant, and the risk of having a child with Down syndrome is approximately 50%. Offspring without trisomy 21 seem to have an increased risk for other congenital and developmental abnormalities. Down syndrome and Alzheimer's disease. Alzheimer's disease is more common and occurs at an earlier age in patients with Down syndrome. A medical evaluation should be performed, including testing for thyroid disease when the diagnosis of Alzheimer's disease is considered. Possible depression should also be excluded. Down syndrome and life expectancy. Life expectancy in Down syndrome is shorter than that in the general population. The median age at death increased to 56.8 years in 2003. The most common causes of death are pneumonia or other infections, congenital malformations, circulatory disease, and dementia.